Thank you very much for the invitation and the introduction. So I was asked by Barbara to talk about translation into clinical applications. So that's what I concentrated on. The reason we study peripheral effects of opioids is, of course, because of all the side effects that are produced that everybody knows: respiratory arrest, addiction, sedation, nausea, vomiting, constipation. And of course, the alternative drug class that we have for clinical use are the non-steroidal analgesics like ibuprofen and related compounds, but they also have very dangerous side effects such as gastrointestinal bleeding, ulcers, even heart attacks and stroke. So we started a long time ago. This is one of our first studies that we published in 1988 in a rat model of inflammatory pain. You've heard about this before, that we inject Freund's adjuvant into the rat paw and into one paw, and the other paw is normal, so we can compare the effects in the inflamed paw to the non-inflamed paw. This is a very simple experiment where we injected fentanyl, a very small dose, directly into the paw interplantar. And you see there is an increase in paw pressure thresholds. This is the Randall-Salido test, selectively in the inflamed paw, but not by the same dose in the non-inflamed paw. The same or an equivalent dose injected systemically had no effect, so this was probably mediated locally. We also tried to antagonize this. You can see this effect can be antagonized by naloxone, a very popular opioid receptor antagonist, but it can only be antagonized by the left isomer, not by the right turning, the other way around, the right turning, but not the left turning isomer, so it's a stereospecific antagonism. So this was really one of the first times that we investigated and we showed that there are effects, but we went on and did a lot of other studies to find out where are these located, these opioid receptors located, where are they synthesized, and so forth. So this is a summary of about 20 years of work where we found there are opioid receptors on the peripheral terminus of primary afferent neurons. This is the spinal cord. These opioid receptors are synthesized in the dorsal root ganglia. They are transported into the peripheral terminals. They get incorporated and become functional receptors. They also get transported into the spinal cord, of course. We also found out that there are endogenous ligands of these receptors, such as beta-endorphin, metenkephalin, and others that derive from inflammatory cells. These inflammatory cells move from the vessel into the inflamed tissue, and they can release these opioid peptides, the green triangles here, and these endogenous opioid peptides can also activate these receptors on the primary afferent neurons and cause analgesia. And there are several factors that release these opioid peptides, for example, also chemokines and interleukins, and also CRF. One important feature, and we come back to this later, is that, of course, as everybody knows, inflamed tissue is acidotic. There is a low pH between 5 and 7. We will come to this later. Another important component is the sympathetic neurons. We also know sympathetic neurons, when there is stress and pain, they can release noradrenaline, for example, catecholamines that activate adrenergic receptors on immune cells, and these adrenergic receptor activations can also release opioid peptides. So one of the first clinical studies that we did just a couple of years later, this is not the first study, we did this in the early 90s. We injected morphine directly into knee joints during operations on the knee joint. As you can see here, a typical arthroscopic knee surgery, and we measured pain by, for example, the visual analog scale on a scale from 0 to 100. There were there was a control group, a saline group, there was a 2 milligram morphine group and a 4 milligram morphine group. This was done in collaboration with Rudi Licker in Austria. And you can see the saline group has a certain level of pain that decreases within the next 24 hours after the operation. But the two morphine doses, the 2 milligram and the 4 milligram dose, produce clearly pain relief that is stronger than placebo. And then years later, there was a meta-analysis. There were more studies coming out, and Eya Kalso, who just introduced this session, did this meta-analysis, and I believe at that time, this was in 2002, there were about 40 studies included in this meta-analysis, and so many different groups did the same thing. They injected different doses of morphine into the knee joint after arthroscopic knee surgery, 1 milligram, 3, 4, or 5 milligrams. And what Eya did in this interesting meta-analysis is she grouped those studies into the first group that looked at pain at a very early stage after the operation, 2 hours after the operation, the second group between 2 and 6 hours after the operation, and the third group between 6 and 30 hours after the operation. And here you can see the positive studies and the negative studies. Of course, there are studies that find an analgesic effect and others that don't find analgesic effects. And you can see in the early, in the group A, in the early stages between 0 and 2 hours, there were about equal numbers of positive and negative studies. There were 7 positive and 7 negative studies. So no conclusion from this group. In the second group, 2 to 6 hours, we find more positive studies. We find 8 positive and 4 negative studies. So it seems like there is an effect detectable here. And in the third group, from 6 to 30 hours after the operation, they found 10 positive and 3 negative studies. So it seems that the longer after this insult injury, after the development of inflammation, the stronger the opioid effect becomes and the easier it is to detect. And luckily, there were even more studies coming out, and this is a more recent meta-analysis of studies published in 2013 in the journal Arthroscopy. Now there are studies including 1,200 patients in total, and they did a formal analysis. Again, they looked at, of course, not only pain relief by the visual analog scale, but also supplemental morphine consumption and so forth. And the end result was that they found a significantly reduced pain scores by intra-articular morphine in comparison to placebo. So from this meta-analysis of many studies and over 1,200 patients, it seems that this local effect of morphine was really robust and reproducible. So that's very important. That, of course, you've heard this before, that you want to be able to reproduce results and confirm results in many studies. So then we went on and we looked at the endogenous effects, and now we are dealing with a number of much smaller studies here. This is one of our first studies in 2007 where we looked at the occurrence of endogenous opioid peptides in human tissue. Again, we looked at patients undergoing knee surgery. We took biopsies from these patients during the operation. We looked at cells in the knee joint, in the synovial tissue, and we looked at sensory neurons in the same tissue, and we found a lot of beta endorphin containing cells in 3 different groups of patients. There is a group of patients with joint trauma. These are sports injuries mostly. There is a group of osteoarthritis patients, and there is a group of rheumatoid arthritis patients. And if you compare the numbers of the Stein cells, here the brown staining, you can probably see that the rheumatoid arthritis patients have more beta endorphin containing cells than the other two groups that have different types of inflammation. And then we also looked at opioid receptors on primary afferent nerves, on the peripheral nerve terminals in the same tissue. This was a staining with a mu opioid receptor antibody, again in the 3 different groups of patients. You can see all 3 groups of patients clearly have primary afferent nerves that are clearly stained with mu opioid receptor antibodies. So this was a confirmation of our studies in rats, and this also was confirmed in humans. And then we did a study where we injected naloxone into the knee joint. This is again a relatively small study with about 50 patients. The same type of operation, arthroscopic knee surgery, 2 groups of patients. One receives saline control injection, the other group 0.04 milligrams of naloxone, which is a relatively small dose compared to systemic doses. And then we looked at pain after the operation for 24 hours, visual analog scale, numerical rating scales, verbal rating scales. You see that all of these different pain scales show you the same effect. The naloxone group has much higher pain scores than the saline group. So that means when you block the peripheral opioid receptors in the joint, the patients have more pain. How does this happen? It happens because the release, the beta endorphin that's released from the inflammatory cells cannot access the receptor and cannot produce pain relief anymore. But how does this interfere with morphine analgesia? You could easily imagine when you release beta endorphin and you occupy the receptor, you won't be able to produce an effect by morphine anymore, by an exogenous agonist. So we tried to look at this. We compared 2 different groups of patients, a so-called negative and a positive group. We looked at the synovial tissue in biopsies. We divided these patients into one group that had a lot of beta endorphin containing cells and another group that had very few beta endorphin containing cells, the so-called negative group, and the first group, the positive. Both groups received the same amount of intra-articular morphine at the end of the operation. And here you see the effect on the pain ratings. Here's the visual analog scale. Here's the numerical rating scale. You can see in both cases the intra-articular morphine compared to the saline group clearly had an analgesic effect over the next 4 hours in all pain scales in both groups. So both the negative and the positive group had analgesic effects by morphine. However, when you compare the difference between these 2 curves, you can see that the positive group even has a bigger difference. So the morphine was working, if anything, it wasn't working less, it was stronger, it was working better. You can see the same thing when you compare the areas under the curve. And we confirmed this in a separate study in Austria, again together with Rudolf Lika. He injected different doses of morphine, 1, 2, and 4 milligrams. Again, 2 groups of patients. One group, the so-called negative groups, that had a small number of inflammatory cells. The so-called positive group that had a high number of of beta endorphin containing cells. And especially at the highest dose of morphine, you can see that the effect on the visual analog scale was the strongest after morphine injection, 4 milligrams, was much stronger than in the negative group. So if anything, the presence of beta endorphin of endogenous opioid peptides does not interfere with morphine. It even enhances the morphine effect. And we have some theories that we looked at in animal studies, but I don't have the time to show you those studies today. So the next question was, does this also work in chronic pain, or is it only in acute pain? So this time we looked at chronic arthritis patients, two different groups. One group was the osteoarthritis group, and then we also had a rheumatoid arthritis group. We injected morphine, 3 milligrams, saline, and the third group received a standard steroid injection. Many rheumatologists use steroid injections, dexamethasone. We looked at pain ratings by the numerical and the visual analog scale. This time, over 6 days after an injection, there's no operation. There's simply an injection into the knee joint. And you compare this saline group here. This is the placebo group. And this is the morphine group, and this is the dexamethasone group. So clearly, morphine, just like dexamethasone, produces an analgesic effect that lasts over 6 days, and the analgesic effect is similar to dexamethasone. Again, these are relatively small studies. Here is another small study, again done in Austria with Rudi Licker. We looked at dental surgery patients. These are patients that came in with a wisdom tooth into the hospital. The tooth had to be removed because there was an inflammation. But not all patients had very strong. Here, one group that had very strong inflammation. This is another group that had very little inflammation. And this is a third group where the morphine was not injected directly into the wound, but it was injected at the mandibular nerve together with a local anesthetic injection. And you can see this time the visual analog scale is shown the other way around. The best effect is found when the patients had strong inflammation. When there was very little inflammation, there was practically no morphine effect. And the perineural injection was also not very effective in this small study. There were other small studies. I cannot show you all the data in, for example, in ultraviolet irradiation. These were healthy volunteers that had inflammation, like a burn injury induced by this ultraviolet irradiation. There's visceral injections, intravesical morphine injections. Again, osteoarthritis, I just showed you. There is one study that looked at local injections in chronic regional pain syndrome. There's topical studies, topical morphine in skin ulcers. There are many small studies. So there is a number of small studies that were all reviewed, and they all showed effects, but again, not very high patient numbers. Now I will show you a number of negative studies that we did ourselves. We also asked the question, could you inject morphine into other tissues, for example, into the interpleural cavity? The interpleural cavity is shown here. This is the lung, this is the spine, this is the spinal cord, these are the muscles in the back, here is the heart. And this shows the anatomy of peripheral nerves here. You can see that in the thorax wall, there are primary afferent nerves. There are sensory nerves that can be blocked actually by local anesthetic injections. This is a very common procedure for thoracic procedures. So we were wondering if we inject morphine into the pleural space here between the lung and the thoracic wall, we were thinking that the morphine would hopefully travel to the primary afferent nerves here between the muscles and would cause an analgesic effect, but it didn't. So in this case, we looked at patients undergoing thoracic surgery, lung resections, for example. We injected a total of 2.5 milligrams of morphine diluted in 30 milliliters. and we observed the visual analog scale over the next 24 hours, and there was no effect. So that was a negative study. Here is another negative study. This time we looked at patients undergoing laparoscopic cholecystectomy, so that the gallbladder is being removed by a laparoscopic procedure. And again, we did different injections. We injected morphine either into the intrapleural space, or we injected it into the intraperitoneal space. And in both cases, we compared this to a local anesthetic injection, to bupivacaine 0.25%, or to a saline injection, a control group. And I can not show you all the data. The intraperitoneal injection was completely useless. There was absolutely no effect, either by local anesthetic or morphine. In the intrapleural injection, we found an effect, but not by morphine. The only thing that worked here was bupivacaine, was the local anesthetic, but morphine had absolutely no effect. The third negative study was done by Halina Machelska together with several clinicians. Here's the clinical part, here's the experimental part in rats. So in this case, we had a new drug, acimadaline, which was developed about 15 years ago by Merck, and it was supposed to be a peripherally acting kappa agonist. It was a very hydrophilic drug that was not supposed to cross the blood-brain barrier, so it was supposed to only work outside the brain and only act on peripheral primary afferent neurons. However, again, we looked in patients with arthroscopic knee surgery. We looked at two groups. One group received 10 milligrams of this new drug. The other one was a control group. There was absolutely no difference between the two groups, no effect. And in the rats, it looked like there was an initial effect in the Randall-Salido test, but then later on, about 3 hours later, we found the opposite. There was a hyperalgesic effect. So in the beginning, a clear anti-nociceptive effect, but then later on, a hyperalgesic effect that was even stronger in non-inflamed paws. So another negative study, and it was probably related to the fact that this kappa agonist had the opposite effect later after injection. So here is a totally new concept. A lot of people started looking at this a long time ago, over 10 to 15 years ago. It was known, it has been known for a very, very long time that morphine gets degraded after you inject it or apply it to a person. It goes to the liver, and the first metabolite is morphine 6-glucuronide. There is a second metabolite, morphine 3-glucuronide. But this one is particularly interesting because it also binds to opioid receptors. It is known from many animal studies that it's practically just very similar agonist to morphine. So the interesting thing about morphine 6-glucuronide is that it is very hydrophilic and it does not easily cross the blood-brain barrier. So people started looking at this and they thought maybe you could avoid central side effects by using this compound compared to morphine. And here's another meta-analysis that was published in 2011. There's a total of over 500 patients undergoing visceral abdominal surgery, mostly gynecological surgery. And again, these patients received morphine or morphine 6-glucuronide intravenously, and you can see both drugs work very well. When you look at the visual analog scale, there's no difference between the two drugs in the pain relief. But when you look at the side effects, it's interesting to see that morphine causes higher scores of sedation than M6G. It causes higher scores of nausea, higher scores of vomiting, and higher scores of postoperative nausea and vomiting together. So this is really pretty positive, if you will. It's not a huge effect, but you can see that there is clearly a significant reduction of side effects by this M6G. Unfortunately, this was not really followed up by the pharmaceutical industry because it's practically impossible to get a patent on this. So the pharmaceutical industry, of course, is not interested in substances that cannot be patented. Now, we went on to ask a different question in this series of examinations. We wanted to know if you inject a standard dose of morphine to a patient after an operation for postoperative pain relief, how much of this morphine effect is mediated in the brain versus in the periphery? How can you find this out? Luckily, at that time, this was about 3 to 4 years ago, there was a new drug coming onto the market, methyl naltrexone, which is a derivative of the standard antagonist naloxone, but it does not go to the brain. It's a methylated, highly hydrophilic compound, and it was developed for a totally different reason. It was developed for the treatment of opioid-induced ileus, but we used it as a tool. We thought that we inject this antagonist, it does not go to the brain, it blocks only peripheral opioid receptors, and if we do that, the patients supposedly are expected to use higher doses of morphine because the peripheral opioid receptors are blocked. So part of the morphine effect is mediated outside the brain, and part is centrally mediated. So if you block the first half, the peripheral effects by this antagonist, you would expect that the patient requires more morphine. And that is indeed the case. In this case, again, patients undergoing knee surgery, knee replacement surgery, very painful surgery. We did this in 2 different hospitals, totally independent, 2 studies. We looked at 8 hours after the operation. We observed these patients with visual analog scales, with numerical scales. So here you see the cumulative effect between the methyl naltrexone and the saline group, the control group. Here you see when the group that receives the antagonists, these are morphine doses at individual hourly time points. Clearly, the methyl naltrexone group uses much higher doses of intravenous morphine compared to the control group. So this is the confirmation of this hypothesis. When you block the peripheral opioid receptors, the patients require higher doses of morphine to achieve the same pain relief. You can see pain scores are the same in both groups, in both hospitals. So that was a good, I think in our case, in our view, this was a very nice confirmation that peripheral opioid receptors are important, and even if you inject intravenous morphine, systemic morphine, about almost half of this morphine effect is mediated by peripheral receptors. So in the last part, I just want to give you a brief glimpse into the future. Of course, we want to exploit these peripheral effects in the future, and we're very actively working on new methods to make new agonists that only selectively act in the periphery to avoid side effects in the brain. So one strategy that we've been following for about 10 years, we're working with chemists at the Free University of Berlin that have developed a polyglycerol backbone, if you wish, a so-called nanocarrier, and they were able to synthesize, conjugate morphine onto this polyglycerol backbone. And the idea is, as we have heard before from Michaela Kress, if you inject this compound intravenously, We know that there is extravasation in peripheral inflamed tissue because there is neurogenic inflammation, there is vascular leakage. So this is a very big molecule. It will extravasate in the peripheral tissue, that's the theory. But it will not reach the brain because it's simply too big to cross the blood-brain barrier. And in the inflamed tissue, there is this acidosis, and there are many proteases, and both of these factors would then release morphine from this huge molecule, and the morphine would act on these peripheral receptors exclusively. So that is one strategy. We've just published a paper that will come out in 2 weeks in eLife, where we actually confirmed that this theory works. And we also have a second, completely different strategy that we developed with a group in mathematics. We thought that the three-dimensional structure of opioid receptors in the periphery, in the inflamed tissue, might be different from the structure of the normal opioid receptors at normal pH values in the brain or in the intestinal wall. So as we know, we said this in the beginning, there is a low pH here, and there are many suggestions from previous studies that low pH increases opioid receptor signaling. And we actually started to look at computer models together with these mathematics people. And what you can see in these models here, the gray color is the opioid receptor, the red color is morphine. And when you look at the binding of morphine to the receptor here, you can see that the binding is much stronger at low pH. This is a pH of 5.5 compared to normal pH. This is a normal pH of 7.4, like in the brain. So this, pardon? Yeah, this is in the computer, yeah? This is an in silico model, so this was really the first indication that there's something happening to the binding and probably something happening to the three-dimensional structure of the receptor. And the reason there is this difference is because the movement of the ligand inside the receptor is much less than in this case, where you can see that there's a lot more movement of the ligand within the receptor. And then we went on to look at, in the computer model, to change different amino acid residues on the receptor. And we found out that the aspartate 147 and the histidine 297 were very important for the binding of opioid ligands. And we went on to look at different ligands, not only morphine, but also fentanyl. Here you can see the fentanyl molecule. And what we found out was that when in the model, when the pKa of this fentanyl molecule was changed, when it was lowered to 6.8, that this compound was only protonated at these inflamed 5.5 environments, but not at normal environments. And we knew this from many other studies before, is that the protonation of this group here is very important for the binding to these two, probably maybe other amino acid residues. So then we constructed a new compound that had a low pKa, by adding fluorine atoms here. The fluorine atoms are very electronegative and they draw electrons and they lower the pKa of this compound. And indeed, this is what we found. The compound was synthesized by a chemical company according to this computer concept. We injected the drug, in this case intravenously, but we did many other studies. We published a paper here that has about 85 graphs. You can only see about 8 experiments here. This is an intravenous injection in the Randall-Salido test. You can see there's the same, no, this is the Hargraves test, this is heat, pain, there is the same effect compared to fentanyl. In the inflamed paw, this is the complete Franz adjuvant model, but there is no effect in non-inflamed paws. So this was according to the theory that this compound would only work at low pH in inflamed paws. It is reversible by this peripherally acting antagonist, naloxone methiodide, versus more, fentanyl, normal fentanyl is only reversible by 50%. Then we looked at other central side effects. Of course, the main goal was to reduce central side effects. We did, for example, a rotor rod test. You have seen the rotor rod test before that shows you motor coordination. There was practically no effect on motor coordination by this new drug, but motor coordination was severely inhibited by regular fentanyl. You can also see that there is definitely constipation. These are the number of defecations measured at different doses. There is absolutely no effect by this new compound. And here is a series of experiments looking at oxygen saturation in the blood as a parameter for respiratory depression. When compared to vehicle, this compound had absolutely no effect on respiration. So there were many studies done and many people involved. I cannot call up all the names, but I would, of course, like to thank everybody at this point and you for your attention. Thank you.
Yes, well, thanks very much. And I was really referring to these two last studies when I said that something really exciting and new. The peripheral opioid receptors have been around longer. Questions, please.
Thank you for your excellent speech. My name is Petya. I'm working in Bulgaria as an anesthesiologist. And I'm interested very much in postoperative pain management, how we can and what we can do actually. I'm doing PhD in this subject and I work in urology. So my question is, I have two questions. The first one is whether do you inject morphine intraoperatively and it is only once? This was my first question. And do you use any other kind of analgesics postoperatively if the patient has any need?
Yeah, the studies that you saw here, right?
Yes.
So we injected morphine into the knee joint, but the patient was allowed to take additional morphine by a PCA pump. So there was no restriction. The patient was allowed to take as much pain medication by PCA pump as they needed. No restriction. Yeah. And the interesting thing was, of course, we looked at the additional morphine consumption as a secondary parameter. And just like the pain scales were decreased by intra-articular morphine, the additional morphine consumption was also decreased, which is a confirmation, if you will.
Very interesting. Thank you very much. And one more question. Do you think that we can use local opioid in another surgery as urology, let's say? Because this is something that concerns me and I'm interested in.
Yeah, I showed you several examples. The intrapleural injection did not work. There was maybe it was not inflamed. That's a possibility, you know. Maybe there was not enough inflammation. In our case, we only did these two studies. But there are other studies, other people who have done this for urology, in urology for intravesical injections. I think there are several positive studies that have done this. There's one or two studies that have done injections in fallopian tubes for gynecological surgery. So there are many examples actually, that smaller studies that have done this, yeah. But of course, we're looking for big studies for confirmation, yeah. Yeah.
This peripheral opioid injection, you showed some data where it hadn't been in post-operative situations, where it had just been in chronic pain states, and you showed the corticosteroid injection as well. So usually when we see those corticosteroid injections, they might have a good effect the first time and for maybe a month or two, but then the second time it's not as good and the relief wears off. Do you think that these opioid injections have a place in chronic pain where there's not this sort of surgical thing, and can they be repeated?
That's a very good question. I personally think they don't have a place because the only reason we did this study, we wanted to show that it works at all, yeah, just once, yeah. But if I look at these patients, they would have to come like every 2 weeks, and there are no patients that would tolerate this for years. And that's exactly why, of course, everybody is looking for new drugs that can be used systemically for oral application, for example. That's why we are doing this, yeah? Because nobody would take this, like repeat intra-articular injections. They wouldn't do this. Yeah.
Sorry, touching back on this question, would you consider that the use of these drugs in MSK conditions like flare-ups in rheumatoid arthritis, where you normally don't inject them with opioids, but if you have a case where a patient comes after a couple of months, would you consider doing these kind of opioids?
Which patients?
RA patients, rheumatoid arthritis.
Rheumatoid, yes.
Flare-ups.
Yes. We are right now doing another study. We've done this small study that I showed you here. We are repeating the same study. We are only looking at rheumatoid arthritis this time because it worked best in this case. So yes, we would consider this, but again, I'm not a rheumatologist, but I cannot really imagine there would be a lot of patients who would come like every 3 or 4 weeks for an intra-articular injection. I don't know how many people would do this. It's not a very pleasant procedure, yeah.
Thank you for your lecture. It was really interesting. I have a question. Did you analyze any other interaction of morphine with other receptors? Because it was already told that morphine may interact with toll-like receptors with MT.
Yes, we've done many experimental studies in rats with selective mu, delta, and kappa agonists. And they all did the same thing in our model. But I showed you this one study where we used this kappa agonist that was developed by this company, acimadaline, which did not work very well. So again, you have to look at different models, at different patients and so forth. In our Freund's adjuvant model, we found very similar effects between mu, delta, and kappa.
A completely different receptor, not from opioid receptor family. Did you analyze it?
Oh yeah, I mean...
Because, I'm sorry, I think that Professor Watkins from United States...
Yeah, there are many, for example, we just saw chemokine receptors, and many other people have studied other antinociceptive receptors, and chemokines is a very good example, yeah. But we've only looked at opioid receptors.
Any further questions? Well, while you are thinking of more questions, I would like to ask about peripheral opioid tolerance. There was a recent paper in Nature Medicine by Coder and others who suggested that both opioid tolerance and opioid-induced hyperalgesia are initiated by mu-opioid receptors, which are expressed on primary afferent neurons. At least to me, who has sort of always thought that tolerance is in the central nervous system and and tolerance doesn't develop to peripheral opioid effects like constipation. This was rather shocking news. So could you elucidate that?
Yes, I would love to comment on that. I would have to come back to Steve's talk this morning. There are definitely many situations where different groups find exactly the opposite. And we've published a study in 2008 by Zöllner et al. He was the first author. We found the exact opposite. In our model, we did not find tolerance at peripheral mu opioid receptors. So different models, different groups, different cities, whatever. That's why you need replication. Yeah.
Yes, and the negative replications are not being published. So this is the problem. So any more questions? So can we conclude that much is in the periphery, but not everything?
Right.
Thank you very much indeed.